Hey everyone, can you guys hear me okay? Hey Marilyn. Hey Joan. Hey Nat in Detroit. Oh, fantastic. This is wonderful. I spent the morning revamping some of my live stream software, and I was hopeful if you guys didn't mind we could jump online. I was hopeful that I would grab some of my friends over in Europe, since I'm jumping on at a different time than normal. Hey, Joe Siders, one of our amazing moderators is here. This is fantastic. Liam, it's great to see you. Danielle is in the house. This is superb. I hate myelin sheaths. I like that name. Brenda's representing PA. This is wonderful. Norfolk, UK. Liam, I was hopeful that I could grab some folks from Europe. Belgrade is in the house. Serbia. I had an amazing week in Serbia a few years back. I oftentimes do my live streams around 6:30 Eastern Standard Time, which is kind of near midnight over in Europe. And so David in London, I hope this is a better time for you. Dan, c'est ça génial que vous êtes ici avec moi. Paris, c'est extraordinaire comme ville. Hey Sorcha, it's great to see you in Ireland. It's not so late in the day for you right now. This is wonderful. Oh, the Seychelles are represented. That's fantastic. Hello, Amy. Good morning to you. Ukraine is in the house. Hey, Alex. Hey, we've got Violet Wonder from Texas. Let's give it a few more minutes and see if we can get that viewer count up to close to 100, and then we'll rock and roll and go live. We've got Kuwait in the house. That's amazing. Absolutely superb. Oh, you're very kind, HJ. I really appreciate it. Sorchi, this is a good time. I'm loving that. Newcastle, UK. I have to share with you one of my most favorite beers in the world. Has that name on its bottle. Canada representing. We got Oklahoma in the house. Denver, Colorado. What's up? You can certainly drink coffee instead of water, Karen. I've had quite a bit of coffee this morning. I just switched over to water. Big hugs for the international family. Love that. I've got my chat pop-ups working again, so hopefully you guys can see that on the live stream now. Ireland's representing. Melbourne, Australia. Gosh, that's amazing. Melbourne representing. Liam, big high five to you, my man. That's fantastic. Would I get another scan? Yes, I would. Susan, I am actually technologically not super awesome, and so it's hard for me. Kevin, yes, Newcastle Brown Ale is a favorite of mine. We've got North Bay, Canada representing. I love that. Is the music too loud? Are we doing okay with the level of the music? UK representing. We've got Italy in the house. What's up, Ren? Great to see you. 100, that was what I was looking for. Let's go live. Hey guys, hello, howdy, hi. Aaron Boster here. I spent the morning kind of revamping some of my technical things here. I'm hopeful that this is going to work well. To be honest, you guys are helping me out, making sure that this works okay. Let me just adjust my screen a little tiny bit. South Africa is in the house. What's going on? This is fantastic. We have Queens representing. I'm loving it. I'm done with coffee, at least for a little bit. Got my water here. Let's break open the San Pellegrino. MS Water Challenge. When I drink, you drink. What's up, Alberto? Germany's in the house. You know, honestly, it was my goal that we would be able to grab some Europeans today, since I normally go online after work, which is, you know, kind of late in the day for you guys. Let's throw up some questions. So here's a question from Martin, and let me see if I can get this so I can read it. So Martin says, hey, from Germany. Wait, it's not working. All right. I'm gonna have to flip around here a little bit so I can actually read Martin's question. Can you tell me what to do if a patient in clinic has MS symptoms and lesions but positive for Lyme in the blood serum? So the concern as far as the differential diagnosis when someone may have MS and we're wondering whether they could have Lyme is to look in the spinal fluid. And so positive Lyme in the serum doesn't mean that they have CNS Lyme disease. In this instance, I perform a lumbar puncture, a spinal tap, and I draw Lyme CSF PCR. And if we in fact see Lyme disease in the spinal fluid, then that's concern that there may be CNS Lyme. If that's negative, I find that to be very, very reassuring. TK throwing up some flames, you know I love that. Thank you very much. Let's see what else we got going on. So Money Mindset Crew, that's a funny name, asks about Zeposia. So in order to think about Zeposia, we first have to go back in time a little bit, and we need to think about Gilenia. So Zeposia is a second generation S1P1 receptor modulator. That's a mouthful. It's in the class of drugs by Gilenia. Now Gilenia came out October 2010, and it was the very first FDA and EMA approved S1P1 receptor. And there's now been several other second generation pills that have come out, which are like Me Too drugs for Gilenia. Zeposia is one of them, Mayzent is one of them, Ponvory is one of them. And those drugs are very similar to Gilenia. In efficacy, I think they're on par. They have a little bit of an upside as far as the way that we can start them. They can be started a little bit faster and more easily. So when you think about the S1P1 receptor modulators, these pills, I think they are very robust in their ability to shut down new MRI activity. I think that they're very robust in their ability to shut down new relapses. I think they're a bit lacking when it comes to progression of disability. I think that's not a strong suit. I think that when you compare them to the B-cell depleters, for example, they don't fare as well. And whereas I used to use them a lot in my practice, I don't very much anymore. Does that make them bad? No, it does not make them bad. I think they're a solid drug, particularly for someone who does not have very aggressive disease and someone who's young and doesn't want to do more than pop a pill once in the morning. But it's a great question, and thank you for asking. So Jenny O is in the house, and Jenny O has a question about Baclofen pumps. Would you use the method as a last resort? I think it would change my life. So Jenny O, this is a fantastic question, and it's no secret that I'm very biased. I love me some Baclofen pumps. I think intrathecal Baclofen pumps are transformative. They're amazing devices. And to your question, we don't use them nearly enough. We should not wait until the last resort. On the contrary, I think that we need to be considering Baclofen pumps much earlier in someone's situation. And so waiting until someone is really, really bad off doesn't allow the pump to do all the things that you want it to do. I think that we should consider a pump test dose, if you meet 4 criteria. So if you meet these 4 criteria, I'm going to offer you a test dose. A test dose, by the way, is where we bring you into clinic, we inject your back and squirt in liquid Baclofen through a spinal tap, and then we observe you for about 6 to 8 hours to see the response that we get. If it's a good response, then we can go on and consider having a pump implanted, but it's a way of kind of test driving the therapy. So what are the 4 conditions where I would say, hey, we should consider a test dose? Condition number 1 is that you have spasticity. Now, that's not intended to sound stupid, but sometimes people have weakness or dystonia or rigidity, and it's confused for spasticity. So we want to make sure that people have spasticity. Cramps, spasms, Charlie horses, limbs that are hard to bend, things that get worse when you're still and when you're cold. And if you have spasticity, that's the first criteria. The second criteria is what you're currently doing. The second criteria is you don't like it. And again, that's not intended to sound dumb. I have patients with spasticity, but they don't care. I'll never forget a gentleman that I took care of in fellowship, so this is quite some time ago. Primary progressive MS, super, super stiff. The guy walked like Tin Man. I mean, really, he was almost robotic in the way that he had to move because his spasticity was so bad. And he wouldn't even take oral Baclofen. And I would beg him, please, sir, consider taking oral Baclofen. He'd say, young man, because at the time I didn't have any gray. He would say, young man, I don't want your medicines. I don't mind. I'm retired. I have nothing to do all day long. So if I'm a little stiff, it doesn't bother me. And that's an example where, yes, he had spasticity, but it didn't bother him. So the first one is you're stiff. The second one is you don't like it. The third criteria is what we are currently doing isn't working. So if you're trying oral Baclofen or oral Xanaflex, tizanidine, and that's not cutting it, either because the doses aren't adequate to control the spasticity, or it's making you groggy and sleepy and having cognitive fog, that's not okay. If you're doing Botox and physical therapy and stretching and dynamic splinting and pills and nothing's working, that's not okay. So if you have spasticity, you don't like it, and what's currently going on isn't working, then those are the 3 of the 4 criteria before I'm ready to offer you a Baclofen test dose. What's the 4th criteria, you ask? You need to be a responsible human being. Having a Baclofen pump requires some responsibility on your part. You can't miss appointments. You must get refilled at the time of the refill. If you have a problem, it could be an emergency and you have to be able to respond. And so I have sometimes young men, generally, who are not the most responsible yet. They're still becoming mature, they're still growing up in some respects, and I don't frankly trust them that, God forbid, if something went south, that they would do the most responsible thing. And so if you have spasticity and you don't like it, and what's currently going on isn't working, and you're a responsible member of your own healthcare, I'm gonna offer you a test dose. Does this mean we have to wait until you're really in a bad shape? No, not at all. I've done a test dose on a guy. I'll tell you this story really quick. This guy was a Harley Davidson motorcycle dude, all right? So, you know, the motorcycle jacket and the big motorcycle, and his passion was riding on the open highway. Now, he had been in a swimming accident where he dove in a lake and it was really shallow and he cracked his head and he hurt his neck bad. And he had a very, very stiff foot. He didn't have spasticity in his arms. He didn't have spasticity in his legs, just his foot. And when he would put his foot on the pedal with the motorcycle to shift the gears, it would spasm and cramp, and his toes would cramp, and he literally couldn't ride his bike. And he tried to get Botox in his foot, but it didn't work. And he took Baclofen, and it made him too sleepy. And so we did a test dose for him, and it worked. And he got a pump so he could ride a motorcycle. Was he severe? Well, not by some people's standards, but the fact that this guy couldn't ride his motorcycle was devastating to him. He had spasticity, he didn't like it, what was working, or what he was trying wasn't working, and he was responsible. And so we did a test dose and he got a pump. That was a great question. One of my favorite topics, Baclofen pumps. Thank you for asking it. You know how this works. When I drink, you drink. MS Water Challenge, yo. I love the hearts, guys. If you like this live stream, give it a thumbs up. You can jump out of the live stream, give it a thumbs up, and then jump back in. Leaving a comment teaches the YouTube algorithm that you like this content. So go ahead and fire your comments in there and hit that heart button. Here's another question. This question comes from Joan. She's transitioning from Kesimpta, or to Kesimpta from Tysabri. So currently on Tysabri and then gonna do Kesimpta. Anything that she should worry about with regards to B cells? Crap cap is rough for me on Tysabri. So when you take Kesimpta or Ocrevus or Briumvi or rituximab, these are B cell depleters, and they work by pushing down the B cells, which is the goal. And I don't think that we have to worry too much about that. There's 2 things that I want to bring up, and this is true with all of the B cell depleters. Number 1 is vaccinations. And so you want to make sure that you're up to date with your vaccinations, which as an adult is normally not a problem. We want to make sure that you mount a response to chickenpox, varicella, for example. If you are inclined to have COVID vaccines, you want to start the vaccines before you start the Kesimpta. And that's one thing that we've learned through the global viral pandemic, that if you've never been vaccinated, and then after you've been on these medicines for a minute, getting a vaccine may not work as well. Now, in Kesimpta, the data that I've reviewed, it actually doesn't look that bad. And so that might not even be that big of a to-do. But that's one thing that we want to think about. The second thing is, sometimes when you take a B cell depleter, it can push your antibodies down. And I'm talking about IgG. And so it's a very easy blood test to check an IgG level, and I think it's responsible once or twice a year for the neurologist to check an IgG level, just to make sure that it's not particularly low. Now again, the early data with Kesimpta doesn't suggest that it really bottoms it out very much. And so I don't think there's a lot of problems coming into that. I think that B-cell depletion is a very effective way of treating MS. I will point out Tysabri is a very effective way of treating MS. And so I'm really delighted that you're going from one highly effective therapy to another highly effective therapy. And I wish you the best of luck. Thank you for that question. All right, whoops, I just skipped past a bunch of questions. Sorry. You guys know that I'm not going to quit my day job as a neurologist because I'm not always very good at manipulating this stuff. Now, I have some new scenes, and this is the scene that I've been working on. So this is not a Snapchat filter. This is a brand new program that I spent some time working on this morning. It has a couple different options, so I just want to test them out. Here's another animation. Ho-ho! So you guys know that sometimes I really enjoy using these filters. And this is a brand new program. It took me like an hour or so to figure out how to load it up. And so this is the first time I'm testing it out. And I'm so grateful that you guys will put up with me. I'm going to answer a question as a cartoon. So this question comes to us from Amy Campbell. Do you think the BTK will be available and affordable for all people with MS to access and use? So that's a great question, but it's not a question I know the answer to. Right now, as you're well aware, the BTK inhibitor molecules are in clinical research. There's many manufacturers that are studying these, and I am involved in many of the clinical trials. So Roche Genentech has a product called fenebrutinib, and at the Boster Center, we're doing multiple trials with them on this drug. Serono, Merck Serono has a molecule called evobrutinib, and they are very far along. They're kind of the front runner in trying to develop this. They'll probably be out to market first, we assume. Sanofi, so Genzyme Sanofi has a product called tolebrutinib, and I'm involved in many trials with them in SPMS, PPMS, and relapsing MS. And we have Novartis, which has a drug called remibrutinib, and I'm involved in a clinical trial with them. And Biogen just came out with a phase 2, so they're kind of way back in the back, but they're trying to catch up as well. And so my point is there's a lot of momentum. There's a lot of manufacturers that are studying BTK inhibitors, but none of them have completed their trials just yet. None of them have reported out their data completely just yet. And obviously they haven't gone to get labels. So typically the way that things work is you finish your trial, and if it's successful, you submit to the European EMA, and you submit to the American FDA, and you go through a labeling process, and we expect that they will receive a label. Then we have to figure out the marketing access stuff, so that comes next. Now, pills are oftentimes less expensive overall than infusions because you don't have to pay for the infusion cost. And so I imagine that if you're able to get access to MS pills, that these pills will be no different. But it's really very far ahead for us to say that. Let me change this up. I'm going to go back to, there's some really weird ones on here. So this one says, oh, says I'm old, which unfortunately doesn't look very different than I am. Maybe we'll do this one just for a hot second, just for something different. So this is a sepia. So this question comes from Shauna, who says, can you have lesions in your vertebrae with multiple sclerosis? Where's this question? I was told that I have rounded lesions, but in the vertebrae. So no. So multiple sclerosis affects the brain and the spinal cord, right? So the cord is neuro tissue. Now, when you take an MRI of the spinal cord, you also get the spine, the bones and the discs. And part of the bone is called a vertebrae. So a vertebrae is a bone. And when you get an image of the bone, you can see what's called a hemangioma, which is just a collection of blood vessels inside the bone. It's not dangerous, it's not bad. Many of us have them. And so sometimes the radiologist will comment, hey, I see a hemangioma in the vertebrae. That is not an MS lesion. MS lesions are only in the spinal cord. So If I was fancier, I could throw up an MRI and I could point it out to you, but no, that's a good question, thank you. And let me just change up the Snapchat again, or the filter again. So I've got a camera over here. Hello, Mom. And so let's use this one for a quick second. So here's a question that I think is a really nice one. Let me throw this up from Tanya Smith. So Tanya says, hi, Dr. Boster. Well, hello, Tanya. Can I ask you, can you have MS with bands in both serum and CSF and have lesions, or does that rule out MS? So let's talk a little bit about MS diagnosis. How do you diagnose someone with multiple sclerosis? There's 5 elements. The first one is the clinical story, the history. All right, so we call that the history of present illness because it sounds fancy, but it's really your experience, which you share with us. And when we're listening to that story, we're listening for either, number one, MS attacks, where over a period of hours to days, you lost a neurological function, so God forbid you can't see out of your eye, or your hand goes numb, or your arm gets weak or something. And then there's typically a recovery. It doesn't have to be a complete recovery, it could be a partial recovery. And we call that an attack. And we're listening for a history of attacks. Or in primary progressive MS, we're listening for a slow, steady decline in neurological function, which is insidious over at least a year. So that's the history that we're listening for. The second thing that we're looking for is exam findings. So when the neurologist runs you through the MS Olympics and they're tracking all the things, they're looking for evidence on exam that supports what you tell us in your story. So for example, if you have had an optic neuritis, we will be able to see changes on the optic nerve when we study it. Either when we flash the light in your eyes or when we look in the back of your eye with an ophthalmoscope. If you have had sensory deficits, we can pick up those sensory deficits on our neurological examination. So the second thing that we're looking at is what we see on exam. The third thing that we're looking for are changes on the MRI. And the MRI has really revolutionized our ability to diagnose MS quickly. When we first picked up using the MRI, the first criteria came out in 2001, we sped up diagnosis ×3, which is awesome. And since then, from 2001, there was a revision of the criteria in 2005, and then 2010, and then 2017. And what those have done is they've let us use the MRI faster and faster and faster, to the point where we can oftentimes, after the first event, diagnose MS just with one MRI, which is awesome. And on the MRI, we're looking for spots, white spots, in certain locations. And there's a bunch of rules. You have to have at least one spot in 2 of 4 locations, or 5 locations. The periventricular white matter, you may have heard of periventricular lesions, the juxtacortical position or the cortical lesions, infratentorial lesions, or spinal cord. And so we're going to get MRIs of the brain, cervical, and thoracic spine MRI to look for that stuff. Then number 4 is spinal fluid. Now, you don't need spinal fluid to make an MS diagnosis, but if you have abnormal spinal fluid, and I'll define that in a second, then it can contribute to the diagnosis, and it can help speed up a diagnosis. Now, to your question. When you check the spinal fluid, you're drawing some spinal fluid and then some blood, right? So you have these 2 fluids. And then you put them into some lab machines, and you look for what's called the presence of bands. Now, bands are really antibodies. And the reason they're called bands is because the way the test is done, they sort of layer out in bands. So you'll see this like strip, and it'll have bands across it. Now, those bands represent antibodies, and you should have more antibodies in your bloodstream than you do in your spinal fluid. And when you run the test, you have these 2 gels, and then you have bands. And if you have 2 or more bands in the spinal fluid compared to the bloodstream, well, that tells you that you have an overly active immune response in your spinal fluid. And so if you have 2 or more bands in the spinal fluid more than you do in the bloodstream, we call that 2 or more unpaired bands because they're not paired in the bloodstream, then that would contribute to an MS diagnosis. Now, there are situations where you have the same number of bands, and that doesn't contribute to an MS diagnosis. Or more commonly, you actually have more bands in the blood than you do in the spinal fluid. So in your question, if you do a spinal tap and you have paired bands, so for every band in the spinal fluid, you also see one in the bloodstream, that doesn't take away from an MS diagnosis, but it does not contribute to an MS diagnosis. And I said there's 5 things, and number 5 is a real big one. Hey, Aaron, prove it's nothing else. And so that's where we have to do the stuff like the Lyme question that I was just asked earlier, to prove it's not an infection like Lyme disease. We have to prove it's not a bunch of other things, like another autoimmune condition, et cetera, et cetera. So that was a great question. Thank you very much. Let's do a little MS water challenge. All right. Chlorine says, have you ever had a patient who had a left temporal lobectomy for seizures and then was diagnosed with MS later? So I have had patients that have seizures and then later on go on and get an MS diagnosis. And as my mentor used to say, sometimes nature is too generous. Now, if you have seizures, does that mean you're going to get MS? Absolutely not. But people with MS have an increased risk of having seizures. And so, sometimes you can have more than one neurological thing going on. Good question. Scotty, I think the Pons device is dumb. Susan asks, is Ponvory a good disease-modifying therapy for people over 65? So I think that really depends on many, many factors. It's not a drug that I reach for in 65-year-olds. Now, that doesn't mean it's not a good drug, and if you're a neurologist and you have sorted out that's a good drug for you, that's cool. The reason I don't reach for Ponvory in a 65-year-old is in a 65-year-old, we certainly want to make sure that we're doing everything we can to slow progression, and I don't think Ponvory is very good at slowing progression. Also, the way that Ponvory works, it can increase risk of certain things that I don't like an increased risk of cancer and infections. And as one gets older, there's an increased risk for that anyways. And so, whereas I wouldn't necessarily use it in a 65-year-old, that doesn't mean that it's off the table and that we shouldn't do it. I'm just sharing with you my opinion. All right, let's grab another question. But first, let's change up. Hey guys, check this out. There's 206 of you. Thank you very, very much. That's amazing. I say this with sincerity that I never imagined that this channel would develop such a robust and beautiful community. That's not something I knew about when I started making YouTube videos back in 2015. I was just making videos because I wanted to educate and share stuff with people. But what I didn't realize was you guys are unbelievable, and you're so supportive of me, and you're so supportive of this channel, and you're so supportive of each other. I love that. I love going back and reading through all the comments, and nothing warms my heart more than when I see 2 people in the chat supporting each other and caring for one another. Same thing when I read the comments in my videos. It's awesome. Someone will share something and someone else will write in and say, hey, I hope you're doing well. And that is just beautiful. The fact that I randomly jumped online today on a Saturday and that there's 200 of you that have joined me is just such an honor. And so thank you, thank you, thank you. That's just really freaking cool. So Violet Wonder shares, I had a horrible flare-up 2 days ago, and I just completed my first dose of Ocrevus. Is that normal? This is an important question, and the reason it's important is because it's important that we understand how these drugs work and how quickly they work. And so what I'm assuming, Violet Wonder, is that you had your first 2 loading doses and that 6 months later you had your first full dose. And so that's what I think you mean when you say first complete dose. And then right after that you had an attack. That's not good. I mean, it's never good to have an attack. And does that mean that the drug didn't work? It might be too early to tell. And so if I was dealing with this situation in clinic, here's how I would approach it. I would present 2 potential options. One option is we cut bait and we switch to another drug. The second option is we put Ocrevus on formal warning. We say, listen, Ocrevus, you had 1 screw up and we're not going to accept any more. And we're going to monitor very carefully. We're going to get MRIs, maybe even get MRIs every 6 months for a little bit. And if anything else happens, we are done. And so Whereas I don't think it's normal. It does happen. I've had it happen many times in clinic, and I think it's a discussion. Now, sometimes it's not the best idea to cut bait right away. I don't know your history and what's been going on, and we might need to give Ocrevus a full year before we really weigh in and decide yes or no. I hope that you've recovered from your attack, or that you will recover from your attack, and I wish you the best of luck. Let's change things up. We're going to use these filters again. What else is going on? These are filters that I haven't really looked at yet. That's kind of a weird filter. Here, we'll blur the background a little bit. So this question is one I like very much from I Hate Myelin Sheaths. Are extended fasts safe? 3, 5, 10. Doing lazy 1 meal a day since April. So as many of you know, I successfully lost a decent amount of weight using intermittent fasting. And I'll be honest with you, the last couple weeks I've been under some stress and I've been cheating. I've been eating later than I'm supposed to. Shame on me. So I've got to get back into my eating from noon to 8 p.m. a lot better than I have been. That's me telling on myself. I think intermittent fasting is really brilliant. I really, really do. And I have successfully worked with patients in my own clinic to use intermittent fasting to lose a lot of weight. And so that's really awesome. There's a lot that has to go into deciding if intermittent fasting is safe. And we have to kind of consider a bunch of factors. So for example, if you're diabetic, not eating for long periods of time can have serious ramifications. Depending on how you take your medicines, that can be a big deal. So this is not something that is perfect for everyone. Although I do think overall it's safe in the setting of multiple sclerosis. Now, I think the question that you're asking is doing an extended fast. So when you say 3, 5, and 10, I think you mean days. So I'll share with you that I personally enjoy doing an extended fast, typically for about 2 days, sometimes 3 days, about once a month. I do not recommend that to my patients routinely because I think that it's even more complicated than standard intermittent fasting. And so before you were to explore doing an extended fast, I think it's important that you talk to a healthcare professional. Now, I want to be honest with you that I don't think a lot of healthcare professionals, at least allopathically trained doctors, know a lot about fasting. And so you might need to find a registered dietitian who has expertise in fasting so that you can really make sure that it's okay. That's a great question, and I like the fact that you're doing this lazy OMAD. That's 1 meal a day. This is awesome. So Shannon Feathers writes, thank you for all your help. You're welcome. These chats and all your videos have helped me understand MS better. Yay, that's my goal. I'm going to see Dr. Pardo's office in September. I'm very excited. So Gabe Pardo is one of the best MS neurologists in the world. He's a friend of mine. He is a brilliant man, really, really smart. He's a neuro-ophthalmologist who specializes in multiple sclerosis. He is a powerhouse of research, and he is a caring, caring doctor. So I feel so happy that you're going to be seeing my friend Gabe. Give Dr. Pardo a big hug for me. The guy is absolutely wonderful. If I had MS, I would see him in a heartbeat. He's a very, very good doctor and a very caring doctor. So Julie shares that the volume is really low. Can you guys hear me okay? I hope that you can hear me okay. Let me scroll down and make sure that I'm not goofing up here. Okay, I'm not seeing a lot of comments that other people can't hear. I hope that you can hear me okay. So let me go back and try to find where I left off. There's a lot of great questions here. I'm just trying to scroll back up so I don't skip past a lot of questions. Here is one of our amazing moderators, Fork UMS. If you guys don't know Fork UMS, you got to check him out. He's got a YouTube channel, and he really comes up with some fantastic ways of using diet and exercise to really beat up on MS. I'm going to change the scene back here. In fact, Fork UMS is oftentimes a participant in our live streams. He's a moderator. He asked a question the other day that I didn't get to, and I saw it afterwards, asking about alpha lipoic acid. So for QMS, alpha lipoic acid can help with pain. The data for alpha lipoic acid is really out of diabetic neuropathy, which is not the same thing as MS myelopathy. But anecdotally, I have had some success using alpha lipoic acid with some patients for neuropathic pain. And I think alpha lipoic acid is pretty safe. And so I was really happy to see that question. He had also asked about some other stuff like, I think I'm remembering off the top of my head, magnesium gluconate. And I've used magnesium successfully to help with bowel problems and with spasticity. So I've saved your question, my friend, and I do plan to answer it more thoroughly in an upcoming YouTube video, but I really appreciated you asking, and thanks for being on the chat today. We also have Even So It Is Well, another wonderful moderator from Connecticut. She also has a YouTube channel, so both of those moderators have YouTube channels. So check out ForkUMS and subscribe to his channel, and check out Even So It Is Well and subscribe to her YouTube channel, because those are great patient advocates. They do amazing things. All right, let's see here. So I've kind of lost my place in the chat, and so if I've missed your question, please don't be upset. I definitely go through all the questions later and extract them out so that I can make YouTube videos. But here's a question from 61 Roxy. That's kind of a fun name. Who says, is there any truth in a study that can... Well, no, that's not the one that I was trying to answer. Sorry. Is there any truth in the study that considers aspirin against overheating? No, not to my knowledge. Here, where my son is, we can't choose to try Ampira if the doctor doesn't want to prescribe it. So I have not had success using aspirin to block heat sensitivity. But I do think that talking to the clinician about Ampira for aminopyridine is a really good idea. I genuinely do. And you know, it's hot in Ohio right now. So as I look outside, the sun is shining and it's getting warm. And a lot of my patients have kind of a short circuit when they get overheated. They either have cog fog or significant fatigue, or they have weakness. And so I definitely think that's a good idea. Oh, we've got another wonderful moderator. Angela is here from Chillicothe, Ohio. Hey, it's really good to see you. Thank you for being here with me today. I'm going to skip down here and try to find some more fantastic questions. So Liam writes, Liam Murphy writes, why would a JC virus positive person be recommended Tysabri when the likes of Ocrevus have similar efficacy and less PML risk? So that's a good question. So I think that there are situations where someone who is JC virus antibody positive might still consider Tysabri, because it's really all about the risk benefit. So if I use a stupid example, prior to cars, people rode horses. And when we went from horses to cars, the number of deaths skyrocketed. There's many more deaths using cars than horses, but I don't see anyone riding a horse. Now, it's a dumb analogy, but my point here is when you take on a car, there's a different risk benefit, and the risk benefit is in your favor driving a car, most people decide. So if we get back to this concept of Tysabri, if you are JC virus antibody positive and you take Tysabri, there may be a very small risk of PML. And depending on the other risk factors, that risk could be 1,000th of a percent or 100th of a percent. Now, 100th of a percent means you take $1 into 100 pennies. You take a penny into 100 pieces, and 1 sliver is your risk. Does that mean the risk is 0? No. Does it mean the risk is really low? Yes. And if you were to extend the dosing of Tysabri out to every 6 weeks instead of every 4, that risk is even lower. So, does that mean that all people with JC virus antibody positivity should all go on Tysabri? No. But I don't think it takes it off the table. I think it's a risk benefit. And there are situations where someone can't tolerate or doesn't want to or is unable for various reasons to do other therapies. Tysabri remains a really effective therapy. I know a lot of really smart MS neurologists that will use Tysabri up front for a year or two before they do anything else. Why? It works really fast and it's really effective. And then they can transition from Tysabri onto something else as that risk might change or go up. Now, I don't disagree with you that if you have JC virus antibody positivity and you want to avoid the risk, that's completely reasonable. And doing something like going on a B-cell depleter like rituximab or Ocrevus or Kesimpta or Briumvi is not a bad idea. And that's a decision that I oftentimes make. But I just want to point out that choice is very important and that everybody should, in my opinion, be allowed to have some say in their own care. And so there are some people where they don't even have JC virus antibody positivity. They're antibody negative. But the fear of PML terrifies them. And I don't think it's my job to talk them into doing that. I have other people that are JC virus antibody positive, and they have a genuine risk. Their risk might even get close to 1%, which is not small. But a lot of these folks are terribly medically savvy, and they've done really, really well on Tysabri, and they don't want to come off. And I don't think it's my right that I can tell them, no, 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 you must come off. Because again, I don't think it's my right to be paternalistic. I think it's my responsibility to be an educator. Now, I have to do something difficult. I have to go to the bathroom. Why? Because I have a 48-year-old bladder, and I've been pounding water, and I've been pounding coffee. And so I'm gonna ask you guys not to run away. I'm gonna sprint to the bathroom as fast as I can. I'm gonna go to the bathroom, wash my hands, and run back, okay? Please don't leave. There's 205 of you. Don't run away. I'll be right back, I promise. Okay, I'm back. So I did lose some of you. I'm sorry about that, but you know, my nearly 50-year-old bladder isn't what it used to be. So thank you for being so kind and patient with me for the 191 of you that stuck it out online. Thank you. So let's keep tackling some questions. So here is a question from Kirsten Van Ziel. I hope I didn't butcher your name. And the question is, what's the difference between PPMS and RRMS? My doctor put me down for an MRI as RRMS when she stated that I have PPMS. It'll be a year on Ocrevus. So this is a good question, and I'm going to change up the filter here. So I'll answer the question with this scene. So I think there's very little difference, to be very honest with you, at the end of the day between PPMS and RRMS. My opinion is that MS is one disease and that this one disease can present itself differently in different people. Now, that is not the majority opinion, but I just think they're wrong. The majority opinion is that PPMS and RRMS are maybe different conditions, but the more I study the data, the less I think that's true. So I'm going to give you the party line, although I really think that they're the same disease and they just present differently. Relapsing remitting MS, or relapsing MS, is typically something that presents in people around age 30, and it's hallmarked by attacks. So someone has an MS attack, which I described a little bit earlier in this live stream. And after an attack with a loss of function, there's a regain of function to some degree, either all the way or part way. And then there's periods of time in the beginning of the disease where the disease is more or less kind of quiet. There is progression, but it's oftentimes early on very subtle. And if you follow a human being who's had relapsing MS for 15 some years, oftentimes they have less and less frequent attacks, but they start to accrue disability independent from attacks. And back in the day, we used to call that secondary progressive MS. Now, primary progressive MS presents differently. It presents without attacks. It presents as a slow, steady decline in function, really without attacks or very, very few attacks. And it typically presents around age 40, about 10 or so years later than relapsing MS. Now, when we've studied the therapies for primary progressive MS, we were not successful with a lot of the therapies showing that they would slow down PPMS. And we concluded that some drugs are good for relapsing MS, but they're not good for primary progressive MS. And in part, I think that's because we studied the medicines wrong. And in part, I think it's because some of the earlier medicines don't do a very good job of slowing progression in anyone. Now, ocrelizumab is the only drug that has successfully received FDA and EMA approval for primary progressive MS. But I don't think that's because it's magic. I think it's a highly, highly potent drug. And I think that if you look at other highly, highly potent drugs, we probably can slow down progression in PPMS. Now, my opinion is that what neurologists have done is they've looked at the outward description, we call it the phenotype, of these various flavors of the same disease, and we categorize them as being separate. And I'm going to give you a very off-color example of what I mean. Here in the United States, someone might say, hey man, look at that buxom blonde, which is a very rude thing to say, a buxom blonde. Basically, you're commenting on two characteristics of a human, the hair color and then one other feature, and you're describing them just by that outward appearance, which is cruddy. When you call someone a buxom blonde, you don't know jack about that human being. You don't know their philosophy on life. You don't know the kind of foods they like to eat. You don't know their life experience. You don't know their politics, their religion. You don't know which books they like to read. You really don't know almost anything about them except these two outward appearances. And when you say that's PPMS, that's relapsing MS, it reminds me of calling someone a buxom blonde. It's a very shallow and surface way of describing the disease. Now again, remember, this is my opinion and it's a minority opinion. Most neurologists disagree with me, but they're not on this live stream, so you're stuck listening to my opinion. Haha! I look forward to a day in the future where we stop describing MS by the phenotype, and instead we describe it more accurately using things like the immunology and the genetics of the condition. And so I envision one day we're going to say this is MS with a Th17 phenotype or with a B-cell predominant phenotype. And we're going to talk about the genetics behind it. And I think that's going to be a much more accurate way of describing the disease. So I hope that helps you. Sorry that I went off on a little diatribe there with a soapbox, but thank you for listening to me. And thank you to 214 of you for listening to me. That's freaking awesome. Thank you, thank you. All right, let's keep going with these questions. So David Guest says that you're a computer science major. Love the filters, especially the ones you make yourself. Thank you. I am not a computer science major, and I'll tell you, my man, I struggle trying to figure this stuff out. And I really appreciate the kind words. Here's a three-dimensional cartoon, so I'll answer this question as a cartoon. And I said this on my live stream the other day, I've had some negative comments about the filters. And a couple comments said that they felt like I was being disrespectful because I'm talking about something very serious, multiple sclerosis. Well, I hope that you know that I take MS very, very seriously. I buried my uncle because of his MS. I grew up in a home where I watched MS destroy a family, my family, before the first MS disease-modifying therapy was available. I have dedicated my life in a mission-driven way of combating multiple sclerosis. I went to school for 27 grades so that I could be an MS neuroimmunologist. And I have trained 5 MS fellows and trained 7 MS nurse practitioners. I started the Boster Center for MS on my own at the very beginning of a global viral pandemic so that I could kick MS in the teeth. I'm very, very, very serious about MS. I make this YouTube channel to educate, to energize, and to empower families impacted by MS because there was nothing like this for my family when my uncle had MS and my grandparents were desperate for help. So when I make these Monday morning YouTube videos, I don't monetize them. I'm not looking to make a buck. I'm looking to educate. And I try to deliver very dragnet, just the facts, straightforward educational information. So when I get on a live stream, I like to change it up a little bit. I like to be a little bit sassy. And it's my hope that the chat, the filters that I use every once in a while keep things fresh and they're kind of fun. But it is not my intention to be disrespectful. And I certainly don't want to come across that way. All right, so Natasha's got a question. Whatcha? Now let's do this one. All right, so Natasha writes, question, switching from Aubagio to Kesimpta. My neuro said no washout with cholestyramine is needed. Will that make me doubly immunocompromised? No. When I switch from Aubagio to Kesimpta or Aubagio to another B-cell depleter, I don't wash it out. So I do exactly what your neurologist does, which doesn't make us right, it just makes us agree. And the reason is, I don't think it's really necessary to wash it out. The only time I really want to wash it out is if someone has a very bad side effect, like if it's damaging their liver, God forbid, or if they become pregnant, and I need to get it off quickly. But otherwise, I don't think there's a big issue with letting it slowly leave your body. It takes about 18 to 24 months when you just stop Aubagio before it's completely gone. Now, I do not view Aubagio as an immunosuppressant. The American label refers to significantly increase your risk of infection in my experience. And so I don't have a lot of concern when I go from Aubagio to Kesimpta. Now, there may be people on this live stream whose neurologists disagree, and there are probably some neurologists that really want to wash it out beforehand before starting. And I don't think they're crazy for cuckoo puffs. I just don't think that it's necessary. So that was a great question. Thank you for asking. All right. So Chris here writes, I'm in the UK. Well, hello over in the UK. I'm trying to get testosterone treatment. Have you done a video on testosterone? Sorry, I have PPMS. So yes, I have done a couple videos on testosterone for MS. And let's talk about it for a little bit as soon as I have a sip of water. MS water challenge. When I drink, you drink, guys. You know what to do. MS is a very complex disease, very complex. There's an interface between your immune system and your nervous system, but that's not the only interface. Hormones can impact multiple sclerosis. And it turns out that low testosterone levels in men with MS make the disease go faster. Allow me to repeat. Low levels of testosterone in men with MS make the disease progress faster, which is jacked up. And low levels of testosterone in men with MS can cause sexual dysfunction, which I don't like. They can also cause cog fog, all right? They can make trouble with thinking. And they can make fatigue worse. So at the Boster Center for MS, we check all men's testosterone levels. And if I find that your testosterone level is low, I refer you to the friendly neighborhood urologist, and we supplement your testosterone. And I have found time and time again that when I supplement a gentleman's testosterone, his energy increases, his cog fog improves, and he regains a lot of sexual function, which I think is a great thing. And we know from clinical studies that it should help slow down the disease. So I think that it's very important that men have their testosterone levels checked. You want to check it in the morning because testosterone is the highest in the morning. And so you want to get the highest level so that you're properly assessing it. Here in the United States, oftentimes we need to document 2 low testosterone morning levels before an insurance company will cover the cost of testosterone. And then we want to follow that level. Now, testosterone has risks. And so there's an increased risk of prostate cancer. And so you need to have PSA checked, and you need the doctor to use the rectal finger to make sure that the prostate isn't enlarged and lumpy and bumpy. And you also need to make sure that you're looking at some other laboratories to keep someone safe. And so there's a little bit of work that goes into supplementing testosterone, but it's not super, super difficult. And I think it's a really good idea. Yes, I do have some YouTube videos on the topic, so you can certainly check those out. So no, I use is no filters. Sorry, but I'm going to be using a couple filters here and there. I guess when I do the filter, if you just close your eyes and wait one question, then you can hear my sultry voice, and then you can open back up and it'll be better again. All right. Let's look for another question. This is a really good question coming from Carissa Bush. Sorry, I'm not very good at pronouncing names. So Miss Bush says, why do I feel worse with no new lesions? And that is a very, very common comment, very common. And it's because you don't have to have new lesions to have worsening in MS. So let's talk about this. There are 4 ways that you can get worse, that you can feel worse in the setting of MS. One way we call RAW, relapse-associated worsening, where you have an attack or relapse and then you don't fully recover. And so you accrue disability. Your exam gets worse. That's not the most common way people get worse in MS. The second way that you can get worse in MS is called PIRA, progression independent from relapse activity. And there's been a lot of focus on PIRA recently. And there's a better understanding that even in early relapsing MS, a proportion of patients get worse separate from attacks. And so you don't have to have a new lesion to get worse. The third way is symptoms that are poorly treated. So for example, if you have depression and it's not adequately treated, you'll feel worse. You will be worse. It colors everything gray. It can actually speed up MS to have untreated depression. If you have a low testosterone level, and the gentleman that I was just answering a question for, it can make many symptoms worse. If you have untreated spasticity, it'll make things worse. Your exam worsens, not because of a new lesion, not because of a new attack, not because of progression, but because symptoms are inadequately treated. And number 4, you don't get a buy from the rest of life just because you have multiple sclerosis, and so you could be worse because of a different different medical problem. For example, undertreated thyroid dysfunction can make you worse. Undertreated high blood pressure or undertreated diabetes, all these things can make you worse. So we have to look at the human being as a whole, and we have to think about all these different things. Are we missing something else medically relevant? Are you having symptoms that are not adequately being treated? Are you having progression, which is independent from relapses? And are you having new attacks? And you don't need to have new lesions to have many of those things happen. That was a very, very good question. Thank you for asking it. So Luca asks, please tell me what you think about Mayzent. I think Mayzent, because I switched to it after ocrelizumab, which didn't help me with frequent exacerbations. So in groups of humans with MS, Mayzent is not better than ocrelizumab. But you're not a groups of humans, you're one human. And for you, maybe it's such that ocrelizumab wasn't the best drug for you. And the proof, my friend Luca, is in the pudding. So if you are stable like Mabel on Mayzent, if you're not having new disease activity, not having new attacks, not having new spots, if you're not having progression of disability, then you may be a responder to Mayzent, and that would be wonderful. And we have to figure that out for you as an individual. Again, in groups, it's not considered superior, but you're not a groups, you're one person. And so I wish you the best of luck. I think that's a great question. So here's a question from Beatrix Lokes. I had a really good friend in college named Beatrix. We called her Bea. And so that's a name that makes me smile. So Beatrix writes, I tried something for my urinary urgency, so I know it's off topic, but I'll share it because it may help someone else. Oh, and then there's a name of a medication, so it's not really a question. So what makes sense asks a sensible question. Question. With being newly diagnosed, when will the doc tell me what kind of MS I have? Is there a test to find out? Sorry, still learning. Well, don't be sorry. That's exactly why I'm here today, so that I can help up your game and help energize and empower and help educate. And so the way that we sort out what kind of MS you're on is by your story. If you've had MS attacks, relapses, flares, exacerbations, those are all the same thing, then you have a relapsing form of MS. If you've never had a relapse and you have a slow, steady decline in function, then you probably have primary progressive MS. This is a very, very appropriate question to ask the MS doctor or the MS nurse. So what I recommend that you do is before you go to your next doctor's appointment, get out a pad of paper and write down your questions. And when you go to the doctor, say, hey, doctor, I have a list of questions. May we please go over them? And they should say yes, and then you should do that. All right, let's see what else we've got here. So Shay asks, could an injury due to a spinal tap and lumbar patch cause MS down the road? No, absolutely not. So Carmen asks, how many days from the first to the second dose of Ocrevus is the first infusion? The first infusion is always divided in two. Why? So that's a good question. So when we give ocrelizumab, which is an infusion in the vein, we give a 600 milligram dose each time you're dosed. But the first infusion we break in half and we give you 300 milligrams, and then 2 weeks later we give you the other 300 milligrams. So it's a divided dose. Then every 6 months we give you the whole 600 all at once, right? So we divide the first dose. Now, why did we do that? Well, the reason we did that was historically, we studied a compound very similar to Ocrevus called rituximab, and that's the way we gave rituximab. And so when we constructed the Ocrevus clinical trials, we kind of copied that. And it's done for safety reasons. You have the highest risk of an infusion reaction with the first infusion. So by breaking it in half, we run that infusion slower, and we expose you to less medicine, and it helps your body acclimate to it so that you tolerate it better. Now, is it always given in a divided dose? Yes. I have tried on occasion to give it all at once, but the insurance here in the United States will disallow that. And really the reasons are not bad. It's for a safety concern. And that's why we do that. But we don't do it afterwards because it's not necessary. And that's a really good question. Thank you for asking. All right, let's see what else we got cooking here. So Brenda says, after being on a drug for several years, should we change up the medication? Not necessarily. So I think we should change the MS medication under 5 conditions, right? And they don't have to be with time on drug. If you have an attack on the drug, that's not okay with me. If you have a new lesion on the MRI, that's not okay with me. If you have worsening of your neurological examination on a drug, that's not okay with me. If the safety of the drug is no longer safe, or if you no longer tolerate it, that's not okay with me. And under any of those circumstances, I think it's worthwhile to consider switching drugs. I'm not saying you have to switch drugs. I'm just saying I would consider it in that situation. So if you are on a drug for 10 years, 15 years, and you're stable like Mabel, you're not having attacks, you're not having new spots, you're not progressing quickly, your brain volume's shrinking at a normal rate, you're tolerating the drug, and there's no new safety concerns, keep on keeping on. I don't think that you just have to change it up because you've been on for a certain amount of time. All right. Oh, we're going back to the Snapchat. So some people are going to be mad at me right now, but please don't be mad. So this is a question that's popped up a couple times, serum sickness. What is serum sickness? So serum sickness is an old concept where back in the days, someone would be really sick. And to try to make you better, they would take horse serum, horse blood, and they would inject it into you. And the antibodies in the horse blood would help beat the infection. But then your immune system would see these foreign antibodies, the foreign blood, and your immune system would get really pissed off and make you sick. And so that's technically, historically, what serum sickness is. And Mary writes, I was told that I have this as a side effect of rituximab after my 4th round. They want to change my drug for the 4th time. So it's possible that you can have a reaction to Rituxan. And it's not, I wouldn't really call it serum sickness. I think they're probably speaking colloquially, but you can have a cytokine release reaction where you don't tolerate the Rituxan very well. Or I guess technically you could build antibodies against the Rituxan in your own body, and then it would make you not tolerate it well. Now, rituximab is a chimeric molecule, which means it's part human, part mouse. That's a lot of mouse, actually. Very, 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 very little human. So when you inject Rituxan into your body, there's a higher likelihood that your immune system will get pissed off as compared to some of the newer B-cell depleters like ocrelizumab, Ocrevus, Briumvi, ufatumumab, or Kesimpta. I'm sorry, Briumvi is ublituximab, forgive me, and ufatumumab is Kesimpta. So those are newer versions of B-cell depleters, and they don't have the same risk of reaction because they've tweaked the molecules in different ways. So Ocrevus is humanized. They replace as much of the mouse protein as they could. Ublituximab is, that's Briumvi, is glycosylated, and so it works a little bit better. And ufatumumab, Kesimpta, is fully humanized. And so these are adaptations to B-cell depletion to make it better tolerated in the human body. All right, I'm going to do this excellent question from, I'm going to butcher your name, Callistos Callie. So if I said that wrong, I'm sorry. Can you talk about the difference between MS and NMO? Yes. So both of these are autoimmune conditions, and both of them can cause attacks, and both of them involve the central nervous system, but they're different. The pathology is different, and the way they manifest clinically is different, and the locations of where they occur are different, and the way that we treat them is different. So multiple sclerosis is an autoimmune condition where there's a problem with the B cells and the T cells, and it can attack anything in the central nervous system, brain, optic nerve, spinal cord. And in the setting of MS, people get bad from one of two reasons. They can have attacks where they don't fully recover, or they can have progression of disability in between attacks. NMO, neuromyelitis optica spectrum disorder, is also an autoimmune condition, but it's driven by the B cells only, right? So it's a humoral autoimmune condition. And it doesn't affect all the spaces that MS attacks. It really focuses on the optic nerves and the spinal cord and only certain areas in the brain, not the whole brain. And there's no progression in between NMO attacks like you see in MS. Now, MS responds oftentimes to steroids, and particularly early on in attacks, people can bounce back very, very well. NMO oftentimes doesn't respond very well to steroids, and unfortunately, NMO attacks don't always bounce back very well. Now, there's a lot of different medicines used to treat MS. In fact, there's I count 27 different formulations of MS medicines that we can use to treat MS. NMO, not so much. We know that B-cell depleters work to treat NMO, and the first-line treatment, in my opinion, is to use a drug like rituximab. Even though that's not FDA approved, I think that's the go-to when we start treating NMO. Now, there's several drugs that have come out very recently. In fact, there's 3 FDA-approved drugs which work to treat NMO, and they're FDA approved for NMO. So Uplenza, Solaris, Enspring, these are 3 FDA-approved therapies which can all treat NMO. And I'll throw in a third condition, which is a cousin of this cousin. So there's MS, NMO, and then MOG, M-O-G-A-D. And MOG is kind of like a variant of NMO. And it's also a B-cell driven disease, but it's different than NMO. And it also can affect optic nerves and spinal cord. Now, if we focus just the last few comments on NMO and MOG, there are specific antibodies which cause NMO and MOG. We don't know about specific antibodies in MS. So in the setting of NMO, we can do a blood test for NMO antibodies, which look at this aquaporin 4 channel. And so you can see aquaporin 4 IgG antibodies, and that's one of the best ways to diagnose MOG, or excuse me, NMO. And for MOG, there are anti-MOG antibodies. So here's the dealio. Sometimes it's very clear that someone has MS, NMO, or MOG, but sometimes it's not clear. And I think as a best practice, if you're being worked up for multiple sclerosis, we should draw an NMO antibody and we should draw a MOG antibody. And that way, if you have those conditions, we're going to pick them up. Now, we've been rocking and rolling with this live stream for about an hour and 15 minutes, and I want to thank all of you for jumping online. There's 234 of you online. My name's Aaron Boster, and as always, thank you for learning about MS with me. I'm going to keep making Monday morning videos as long as you keep watching them. And if you like this live stream, give it a thumbs up. Leave a comment. That teaches the YouTube algorithm that you really like this content. And if you haven't subscribed to the channel, please consider doing so. So I'll look forward to seeing you on my next Monday morning video. Until then, this is Aaron Boster, as always, saying be safe and take care, guys.